We'll be starting in a couple of minutes. Could everyone hear that? Hello?
Hello. I can hear you.
Okay, great. Okay, Harold.
Ready?
Could you hear my intro?
No, I did not hear your intro. Okay.
Oh, my goodness. I apologize, everyone. I don't know what happened there. Welcome to the American Academy of Physical Medicine and Rehabilitation's webinar on alternative payment models, part of the Academy's Advocacy and Health Policy webinar series. Before we introduce our guest presenter, please know that this webinar is being recorded and will be posted on the Academy website at a later date. We ask that you please type any questions you have during the webinar into the question box on your computer screen. And any questions we do not answer tonight, we will answer you individually via email after the webinar. And slides will also be distributed to you after the webinar. We are delighted to have Harold Miller as our guest speaker today to talk to us. Harold is the President and CEO of the Center for Healthcare Quality and Payment Reform, and he is also an adjunct professor of public policy and management at Carnegie Mellon University. He is a nationally recognized expert on healthcare payment and delivery reform and is currently helping a number of regions and medical societies to design and implement payment and delivery system reforms. Harold recently spoke to the Academy's Board of Directors on this same topic. The Academy thanks Harold for sharing his knowledge to this broader Academy audience. I now turn it over to Harold, and hope everyone heard this time.
Oh, well, at least I did. Thanks very much. And hi, everybody. Thank you for taking time, some of you very late in the evening, to talk about how do you pay differently to get better care for patients. So I'm going to cover a lot of material tonight. I'll warn everybody in advance that there's a little bit of a lag sometimes in the slides changing. So if it appears at any point that I'm talking about something that you're not seeing, just hang on. It'll hopefully will show up briefly. And at any point, I'm going to do questions at the end. But if you have, along the way, if you have a question, just note that in the chat box. And we can make sure to call on you at the end. Sometimes it really helps, because I'm going to be talking about different approaches to changing payment. And sometimes it helps significantly to think about, sort of open your mind and think about differently the way to look at healthcare. And I'm going to do that tonight by just a little thought exercise to begin with. And I'll ask, what if we paid for cars the way we pay for healthcare? And what if it was the Affordable Car Act rather than the Affordable Care Act, with the goal being giving every citizen affordable transportation? And if you said, okay, if we want to make sure that everybody has affordable transportation, we're going to give them insurance that would cover the cost of new automobiles and repairs when needed. And if we had a system like that, you'd say, well, how in the world would we control spending on cars if insurance is paying for them? Now, if we did things the way we did it in healthcare, what would happen would be that the government would come along and would say, well, we're going to set fees for every car part that we pay for. And if that slide would change. It hasn't changed for you guys yet, has it? It's coming here, hopefully. Well, let me just keep going. You would have the government setting fees for every car part, and you would be paying the individual auto workers based on how many parts they installed. And I think people would say, boy, that would be a pretty strange system if we ended up doing that. And I have a wonderful illustration for you to look at, which I'm having trouble getting to show up here on the screen right now. So that's what you would be seeing, is you would be seeing a government list. I called it here just for fun, the HCPCS codes, the Hierarchical Car Parts Compensation System, and the CPT Car Parts Token System by which the auto workers would pay. So my little thought experiment is, so what would happen for drivers if that happened? Well, you would probably say that you expect cars would get a lot of unnecessary parts. And if you got paid by the part, you'd end up with cars being readmitted to the factory a lot of the time to correct malfunctions. And this might occur even though you had accreditation systems in place for the factories, and if you had all of the auto workers certified by some national organization. You would also expect probably that spending on cars would grow pretty rapidly, both as a percentage of the national economy and as a percentage of government spending, because if the government was subsidizing those who couldn't otherwise afford to buy insurance, then the government would be spending more and more on cars. And that's also showing up slowly here. So you would say, well, if that were the case, what would the government do? So it's spending too much, so what would it do? Well, if it was behaving the way it's been doing the healthcare system, it would say, well, we're going to cut the fees for the parts and the assembly, the people who assemble the cars, because if we spend too much, we'll pay everybody less. And then if you think ahead, so what would likely happen? Well, if you were cutting the fees for the parts and assembly, you would probably end up with even more parts being used, and you would probably see the factories merging to try to resist the cuts in the fees. Somebody might come up with the idea of saying, well, let's pay bundles instead of individual parts. So rather than paying individual parts for all of the parts of the engine, let's pay for a whole engine. But if we just paid for those slightly bigger groups of parts, what we might end up seeing is we might get lower cost engines to be able to put in the car. But we'd probably have people putting in even bigger engines to the car to try to make up for what they were losing in terms of the revenue that they were getting. And that whole process might continue rapidly to the point where we were getting bigger and bigger engines in the cars because, of course, insurance was covering it. And we'll wait for that to show up on the screen. I think this is the problem of using graphics. Well, sorry, I'm just going to keep going here so I don't lose too much time. What might end up happening then is that the government would end up setting up what one would call a consumer-directed car payment system, where it would say, well, we'll charge you higher co-payments or co-insurance or deductibles, high deductibles for the cars. But the challenge with that would be that the expensive cars would basically be the same cost as the lower price cars, because if you're paying $1,000 copayment, then you're paying the exact same price, the exact same amount for the $18,000 Ford as you were paying for the $300,000 Ferrari. And you can see appearing on the screen there my vision of what would happen if you were paying for more expensive bundles along the way. And the other problem that would occur is if you had high cost-sharing rates is that people would probably short on the preventive maintenance for the car and not spend money on the oil changes and the preventive maintenance because they'd have to pay for those co-pays, and knowing that even if they didn't maintain the car very effectively, that they would be able to get a new engine covered by insurance because insurance would cover that. And that's exactly the same kind of thing that we're seeing, obviously, in healthcare. And you might say, well, then what else might we do? Well, if we followed what is happening today in a lot of insurance programs, they're inventing what's referred to as shared savings. And if you say, well, how would that work in the world of autos? It would mean that you'd keep paying the factories and the workers based on the number of parts that they would install. And then after they sold the cars, you'd figure out how much they spent to build the car. And if it turned out that one manufacturer was spending less than another manufacturer, then they would get some of that back in terms of a shared savings payment. And if you said, what might happen as a result of that, you would probably say, well, some factories would probably end up reducing parts, but they wouldn't do it enough to be able to get shared savings. Some factories might actually spend more to be able to achieve good quality cars than they received in shared savings payments. Some factories might leave some parts out where there wasn't any quality metric to try to be able to hold them accountable for that. And a lot of factories and workers would probably end up losing money and going back to business as usual. Sounds kind of silly in the world of cars, but that's exactly what we're doing in healthcare today. So is there a better way? Well, what you would say is we should do what we do today with cars, which is we pay for complete cars, and we pay for them with warranties. We don't pay people for the individual parts for the car, and we don't pay them for repairs that are caused by poor maintenance that they do themselves. And what you would think you would want to do is to say, as we do today, is that people have to pay the last dollar of cost. So if they buy a more expensive car, they pay the difference in the price of the car so that they're sensitive to those price differences. And you would say that people would, in fact, need to pay for the preventive maintenance because they wouldn't be paying they would have to pay for the deferred maintenance problems if they had those occur. And perhaps the most important principle of all is you would say, well, we wouldn't actually be guaranteeing somebody a car. What we would want to do would be to say, let's help people get transportation, not just a car. And if we just cover with insurance buying a car, then everybody's going to buy a car, even though a taxi ride, a bus ride, a Lyft car, a Uber car would be a whole lot more efficient way to go. So you'd say, now, if you jump back to the current situation in the U.S., we've got an Affordable Care Act, and the goal is to have every citizen having affordable health care, and the method for achieving that goal is to give every citizen insurance that would cover the cost of health care services when they need it. So the question would be, how do you control spending on cars when insurance is paying? Should we be paying for parts? And I'm clearly way behind on the slides here. I knew this was going to be a problem. So let's see if we can get this caught up here. So if you'll all just hang on for just a second. So the problem today with fee-for-service, a lot of people refer to the notion that it encourages volume. And this has led to the notion that somehow we have to give providers incentives to do higher quality. I think that we actually have a system today in healthcare where the problem with fee-for-service is the barriers that exist in fee-for-service to high-quality, affordable care. The barriers are that there is lack of flexibility. So just like I said that if somebody needs transportation, the best way to do it may not be to buy a car for them. The problem is today what we pay for in fee-for-service is we pay for office visits with physicians and we pay for hospitalization. We don't pay for phone calls or emails with patients. We don't pay for primary care physicians to be able to talk to specialists on the phone. We don't pay for non-physician supports like nurse care managers to be able to work with patients with chronic disease who may need help to be able to manage their conditions. And we don't have any ability to shift resources across the silos of healthcare. And that means that if you'd be better off spending money in post-acute care than a hospitalization, you don't really have the flexibility to do it. And if you need money to spend on outpatient care, you can't always find the money to be able to do that. The other problem is the penalty that exists for quality and efficiency, is that because doctors are paid for individual services, if they can manage patient care with fewer services, they lose money. And hospitals lose money. And the most fundamental problem with the healthcare system today, in some ways, the payment system, is that if you keep your patients healthy, you don't get paid at all, which is not exactly a prescription for success. And how are payers trying to solve this problem? Well, they're not actually changing the fundamental fee-for-service system. They're trying to change the system by adding these very small pay-for-performance add-ons or very small per member per month payment add-ons or small shared savings payments add-ons to what is really fundamentally still the same fee-for-service structure. And it's hard to imagine how we're going to solve those kinds of barriers just with small band-aids on top of the existing fee-for-service system. And if you look at where Medicare particularly is going, that's really getting pretty significant because over the next 5 or 6 years, the projection is that Medicare fee rates are going to be cut by as much as 13% or more for physicians with all of these incentives that are being added on through meaningful use and PQRS and value-based modifiers. So we basically are continuing to have a fee-for-service system with physicians getting paid less and less and less for the individual things that they do, rather than actually having the flexibility to be able to change the way care is being delivered. And where They're lagging. The slides are lagging behind again. Sorry. So for those in the audience, I don't have any way to speed up the rate at which the slides come down to you. So I'm just doing my best here to try to keep up. So some of you, I should warn you, if you're on a slower internet connection, may be seeing the slides more slowly than others are. Again, we'll send out the slides afterwards, so if you had trouble following anything, but hopefully it will get a little bit better as we go along here. So at any rate, rather than paying for parts, we should really be trying to pay for whole products. And so if you look at what we should be doing in payment reform, there's really three models, fundamental, what I sometimes call building blocks of payment reform, that try to address these kinds of issues. One is the notion of a bundle, and people refer to bundles in a lot of different ways, but the real fundamental notion of a bundle is that rather than paying everybody separately for delivering care to a patient as part of a coherent treatment or plan of care, you want to pay a single payment for those folks who are working together. The second big idea, if you will, in healthcare payment reform is the notion of a warranty, which is we do in every other industry, and the idea is that rather than paying more for correcting the preventable errors and complications, we should pay more for the basic high-quality care and then not pay for correcting the preventable errors and complications, which again is the way we do it in every other industry. And the third big idea is the notion of a condition-based payment, which is that rather than paying based on individual procedures, what we should pay is for what the patient actually wants, which is to have their condition managed effectively. And those three building blocks, bundles, warranties, and condition-based payment, really can help a lot of different specialties to be able to manage much more effectively. And the concern a lot of people raise sometimes is that do these payment models, are they still going, if you're going to save money in healthcare, are they simply going to still cause physicians to lose money? Well, to understand that, you have to look at where the money is going today. And if you look at, take Medicare spending, for example, out of what is close to $500 billion in Medicare spending today, physicians are only getting about $70 million of that, 16%. So the physicians get 16% of the total spending. But if you think about it, the other 84% is mostly things that physicians prescribe or control or influence in some fashion. So the solution to healthcare reform and better payment reform is to say, well, if we can actually have physicians find ways to be able to reduce that 84%, not the things that they get paid for, but the hospitalizations and the drug costs and the post-acute care costs and everything else, you could actually pay the physicians more and still save money for payers. And the problem is that the way Medicare payment silos are defined today, there is a cap on what physicians in total can be paid. That's the sustainable growth rate cap. And so what that means is that you can't pay a primary care physician more unless you pay a specialist less, which is not exactly a prescription for collaboration in healthcare. But if you think about having physicians starting to take accountability for the other kinds of costs, it's entirely possible that you could have both the primary care physicians and specialists paid more by being able to reduce the hospital costs, the post-acute care costs, and the drug costs, and reduce total spending in that way, and still have the physicians be able to be paid more. So if I can get my slides to catch up here, I'm going to try to walk through quickly each of these concepts of the bundles, the warranties, and the condition-based payment to be able to show you kind of quantitatively how these things can work, and hopefully that will be something that will enable you to sort of understand how we can actually make the numbers work effectively to be able to be beneficial to physicians while still being able to save money for payers. So I have to pause here for a second to be able to get my slides to catch up. We had thought we were going to have a slightly different mechanism of being able to show the slides when we set the webinar up, so we apologize to everybody for having this. It's always a technical glitch. Anybody who's ever done presentations and things, you know, it's always a technical glitch. So that's our little technical glitch for tonight, is that it's not moving quite as fast as we had hoped it would. So what I'm going to talk about first, as you'll see whenever the slides catch up, is I'm going to talk about first a bundling example. And I'm going to give you a hypothetical scenario for post-acute care. And in my hypothetical scenario, I'm going to have 500 patients who get treated and discharged from the hospital. So I'm going to assume these patients are getting some kind of surgical procedure, and they're being seen by a physician, by physicians both during and after the hospitalization. And the 500 patients are going to be seeing the physician, and the physician total payments are going to amount to about $1,100, of course, across this entire episode of care. The hospital gets paid $15,000 for the hospital stay. And then I'm going to assume that 80% of the patients are going to go to a skilled nursing facility for rehabilitation services. And I'm going to assume that 20% of them today just get home health care. And the physician or physician group that's taking care of the patient is going to be managing the patient care both during the hospitalization and during the post-acute care phase. So for my simple example, I'm going to have basically a group of physicians working as a team to be able to manage it. So this could be surgeons and physiatrists jointly managing care of a knee surgery, for example, or a hip surgery, or something like that. And with the kind of numbers that I'm using here, I'm assuming $15,000 for the hospital payment, $15,000 for the SNF payment, $5,000 for the home health payment for this entire episode of care. What that means is that on average, on total for these 500 patients, they are the payer, and I'm using sort of typical Medicare kinds of numbers here, the payer is spending $14.5 million across all of these 500 patients. Now, a significant fact in all of this is that the physicians are only getting a very small piece of this money. Physician payments total are $550,000 out of a total of $14 million and $14.5 million. So what that means is that there is a lot of potential room to be able to shift the money around in a way that saves money for payers but doesn't necessarily hurt the physicians. Now, it's pretty clear in the system today that if you would find a way to be able to reduce post-acute care costs, so if you could say, well, we think that by better, closer management attention to the patients, we could reduce the number of patients going to skilled nursing facilities, which are very expensive, and have more patients going to home health, that would potentially save a lot of money. I mean, if you substitute a $5,000 home health episode for a $15,000 SNF episode, then you would be potentially saving a pretty significant amount of money. But the way things happen today is that none of that money goes to either the physician or the hospital. And in the little hypothetical scenario that I'm giving here, if you would reduce the skilled nursing facility visits from 80% of patients to 70% of patients, you would potentially save $500,000 for the health plan, but none of that would go to the physician or hospital. And you can see there, hopefully, on the slides, at least some of the numbers that I've been trying to talk about. One way to say, well, how can the physicians in the hospital benefit by doing this better management would be to think about this as a bundle, to think about the physician services, the hospital payment, and the post-acute care costs as an entire bundle of care, and that rather than paying individually, what you would say is, so what are we spending today per patient? Well, what we are spending today, that $14.5 million across the 500 patients, is an average of $29,100 per patient. So if you could say to Medicare, to the health plan, whoever is paying for this, we think we can do that for less. My hypothetical starting point would be to say, what if we can do it for 1% less, just a small amount less? But we'll basically give you that at a lower price than you're getting today. So we'll tell you it's only going to cost $28,000 per patient. But now give us the flexibility to figure out what we should be doing within the bundle. Don't just pay us on the current fee schedule. Let us figure out how much we need to be able to use for skilled nursing facilities and home health. Let us figure out how much we need to be able to cover the hospital costs. Let us figure out what the physician needs. And we might decide, for example, that we need a nurse care manager who might work under the supervision of a physiatrist to be able to work with these patients and make sure that they are getting good coordinated care so that if they go home with just home health, they are getting the appropriate kinds of services that they need, and we don't have to worry about the fact that they're not in a skilled nursing facility. Now, that would basically end up with being, if you could do that, you could potentially save the payer money, but you could also potentially pay the physician significantly more. And what you'll see when I get my slides to catch up here again is that I suggested here that you could actually be able to pay the physician 25% more than they are being able to be paid today, and be able to hire an $80,000 a year nurse care manager, and be able to pay the hospital more than the hospital is getting paid today, and still save the payer money. And where does the money come from? Well, the money comes from being able to reduce the need for expensive skilled nursing facility patient care for those patients who don't actually need that. So if you did that, you would end up with a win-win-win-win. You would have the patients being better off because they're able to go home sooner and to get better, more coordinated care. You would have the physician winning because they're getting paid more. You'd have the hospital winning because they're getting paid more, and you'd have the payer winning because they're spending less. And the reason why you can get the win-win-win is because you actually have the flexibility to be able to rearrange the money. Now, obviously, the skilled nursing facility may not be thrilled about that idea, but if you're actually doing this inside an overall system, you may actually find that that's a better way to be able to cover your costs. So that's the first example of the win-win-win-win concept, is to be able to rearrange the kinds of care that's being delivered within an episode of care. And once you have that bundle, then you actually have a virtuous cycle starting, because you could say, well, if we can do even further rearrangements of the care, let's suppose that we could reduce the use of skilled nursing facilities to 60% of the patients. That would generate even more savings. You could give the payer a lower priced a bundle of care than they were getting before, a 3% savings. Pay the physicians even more, have the hospital make even more. So that win-win-win concept is not only just rearranging the money at one step, it also completely changes the incentives, because now if you can redesign care, you can keep the savings, and you can define how much of it goes back to the payers rather than today where the payers keep it. And there are huge opportunities in the post-acute care area, which is why Medicare is very focused on that. For example, today, if you look at where Medicare spending is going, for many, many kinds of hospital admissions, and you'll hopefully see in a second the slide that shows inpatient costs and post-acute care costs for patients with stroke. But the patients are actually getting more. There's more spending going from Medicare to the post-acute care costs and to hospital readmits than are actually going to the initial patient admission to the hospital and the physician, and not by a small amount. What you can see is that on average, the post-acute care and readmission costs are actually 2 to 3 times what's being spent on the inpatient admission. And we also see that if you look around the country, there's a lot of variation in the post-acute care spending, which means that there are opportunities, particularly in some states, to be able to significantly reduce that because patients with similar kinds of conditions are being managed at a much lower cost in other parts of the country. So that's the notion of a bundle. Warranties sound a lot scarier to people sometimes, even though they're being done in other industries, because the idea is, well, how do we know that we can control these preventable complications? Warranties kind of sounded like a very foreign idea in healthcare for a long time, but the Geisinger Health System started to do this a number of years ago now. Almost 10 years ago, and they didn't call it a warranty. They call it proven care, but New York Times call it a warranty. But the basic idea is that we'll include the costs of not only the physician and hospital services, not only the costs of post-acute care, but we'll also include the cost of any related complications or admissions, all in a single price. Started doing this with cardiac bypass surgery initially, and then have been systematically expanding it ever since to other kinds of conditions, hip replacements, back pain, etc. Now, the myth that's developed is that you have to be a big integrated delivery system to be able to do something like this, like a Geisinger. But the earliest documented example in the literature of anyone doing a warranty was actually done by a single doctor, an orthopedic surgeon in Michigan 30 years ago, who basically said, I'm going to offer a 2-year warranty on my shoulder and knee operations, and anything goes wrong, we'll fix it free of charge. And it's in the literature. The health plan spent 40% less. The surgeon got 80% more payment, and the hospital also made more money. And the reason was because they could redesign care in a way that eliminated all the unnecessary services without having to worry about being paid less. Now, the two important things to understand about a warranty is it is not an outcome guarantee. It is not guaranteeing that there will not be an infection or a complication or a readmission. It's the same as when you buy a warranty on your car. Nobody's guaranteeing you that the transmission won't break. They're simply saying that if it does, we will fix it at no extra charge. The other thing, which is kind of a mind bender for a lot of people about the notion of a warranty, is that the price of warranty care is actually going to be higher than unwarranted care today. Now, most people are used to this concept everywhere else. You'd say, how would you expect to pay more for a car with a warranty than a car without a warranty? Well, of course you would. But the reason why you would do it is because you know that if you have the warranty, then you don't have to pay for the repairs that you might otherwise incur. So you're willing to pay more up front because you're avoiding those extra costs. So let me give you an example of how this would work. I'll try to show the numbers, again, as soon as I get my slides to catch up here. But my example is going to be, I'm just going to take kind of a hypothetical example of somebody being treated in the hospital, and the basic procedure cost is $25,000. I'm just going to use round numbers. And I'm going to assume that 10% of the time, the patient is readmitted to the hospital, and when they're readmitted to the hospital, there's another $25,000 cost for that additional hospitalization. So in that scenario, what you end up with is the actual average cost per patient for these admissions is really $27,500. It costs $25,000 when it goes well, but 10% of the time there's an extra $25,000. So the payer is actually paying $27,500. So the question would be, so what would you charge if you were going to give this procedure with a warranty and not charge for any of the readmissions? Well, the answer is you'd charge $27,500, because if you charge $27,500 per admission and you didn't charge for any of the readmissions, then you would be getting exactly the same amount of revenue that you were getting before. So the question is, well, why would you do that? Well, the reason is because all the incentives now change. Because now those readmissions are costs to the system, not revenues, because every one of those patients has to be treated whenever they come back in. So if you could reduce the rate of readmissions, then your costs will go down. But because your payment is no longer dependent on the readmissions, your revenue would not go down, which means that if you can reduce the rate of readmissions, then your margin actually goes up, which is very different than today. Today, your margin goes down if you reduce readmissions. So the idea is, how could we actually align the quality incentive, reducing readmissions, with the payment incentive to be able to have you make more money? Now, of course, we want to save a little bit of money in healthcare. So now this hospital and physicians that are offering this procedure with the warranty could say, well, let's charge less. Let's charge, we'll charge the payer $27,250 per procedure rather than $27,500. So the payer will save money, and we'll still be able to be ahead in terms of the margin compared to where we were before. And this virtuous cycle continues, because if you can keep driving down the rate of readmissions or infections or whatever it is that you're warranting against, your costs will go down because you don't have to treat those problems anymore, but your revenue will not decline proportionally, and you will control how much you want to be able to charge for that procedure. So in the end, what you end up with, again, is a win-win-win. You end up with a situation where the quality is better because the readmission rate is lower. The cost to the payer is lower because the provider can now offer a lower charge. And the provider is more profitable because they're actually able to generate a higher margin even whenever they charge less. So that's the notion of the win-win-win under warranties. Now, to do this, you have to have data, and this is a big challenge for a lot of physicians and hospitals. You have to know what your readmission rate is, and you have to know what your infection rate is, so that you can figure out, if you're going to have a warranty, how much you should charge for it, and make sure that that's going to cover the cost of what you do. And the purchasers and the payers need to know what the current utilization and costs are too, so that they know whether they're getting a better deal with the warranty if you just give them a warranty price. And both of the sets of data have to match. So this is one of the big important issues for physicians around the country, is being able to get access to the data that they need to be able to price these kinds of models. Now, important thing is that you need to risk adjust these warranties. You wouldn't say, I'm going to give a warranty in the same price for every patient when some patients are at a higher risk of readmission or infection or whatever you're warranting in others. So you'd want to have some risk stratification of the patients and say, for the higher risk patients, I would charge more because I would be expecting to have a higher readmission rate. And for the lower risk cases, I would charge less because I would be expecting a lower readmission rate. But within each of those different payment amounts, you would still have the incentive to try to reduce the readmission rate from a higher level for the higher risk cases and reduce it from a lower level for the low risk cases, because in both cases you would then, as a provider, be able to improve your margins as well as improving care for the patient. And that slide hasn't shown up yet either. Now, what CMS has been doing is recently is a whole series of bundling demonstrations that include all of these exact kind of opportunities I've been talking about. So for whole variety of different conditions and procedures that start in the hospital. They are doing bundles that include the hospital, the physician, the post-acute care, and the readmission, so that's the warranty piece. They're also doing a model, this Model 3 in the Bundle Payment of Care Initiative. It's just a post-acute care bundle. So it doesn't include any of the costs in the hospital, but once the patient leaves the hospital, there's a bundle that includes post-acute care costs and physician costs and readmission. So all of these provide the opportunity for some rearranging of the money to be able to potentially enable the patients to be better off and the physicians in the hospitals. And there's a lot of those projects now going on around the country. I don't know how many of them are involving physiatrists, but I bet that a lot of them probably should, because if you're saying how can we actually manage post-acute care more effectively for patients, you would want to have somebody who knows how to do that effectively in order to be able to make it work. Okay, so the third of the three models that I talked about is the notion of condition-based payment. Here, this is in some sense the biggest change, which says rather than paying for procedures, let's pay for managing the patient's condition. And this can be a win-win-win, because if you don't need to do a procedure on the patient, you don't lose payment, and Medicare, the health plan, doesn't have to pay if a procedure isn't needed. So my final hypothetical example for the evening here on the payment models is I'm going to talk about treatment of back pain. So I'm going to assume that I have 300 patients who are coming to a physician practice for help in dealing with back pain. And the physician practice evaluates the patients to determine whether they're appropriate for surgery or not, and decide that they will do, the patient is appropriate and needs surgery in 2/3 of the cases. They're going to use physical therapy for the remaining 1/3 of the patients. And I'm going to importantly assume here that 10% of those surgeries could be avoidable if you had a better process for non-surgical outpatient management of the patient to be able to deal with their pain more effectively. So what the numbers look like, which again you will see hopefully momentarily when the slides change, is that the doctor is getting paid fairly small amount for evaluating the patient. Just a one E&M payment to do the evaluation, getting paid a very small amount for managing the patients who get non-surgical intervention, get paid for the physical therapy services, but we get paid a lot for the surgeries. So $2,200 for each surgery, but only $250 and $500 for the physical therapy and management. And these procedures are done in the hospital, obviously, so the hospital gets paid $22,000. Now, key thing to notice on this is look at what the physicians are getting. The physicians are getting only about 10% of the total money here that's going to these cases. Now, if you even hinted that you thought that 10% of these patients didn't need surgery, you might have a health plan jump in and say, well, we're going to put a prior authorization system in place to try to prevent those patients from getting surgeries. And if you did that, what would happen would be obvious, that the surgeons would lose money. If they were part of a group practice, they would lose money, and the hospital would lose money because that's how they're paid. They're paid for doing surgeries. So that's basically a losing proposition. So what's a better way? Well, a better way gets back to the notion I was talking about way back at the beginning of the presentation, which is that rather than paying for procedures, we should pay for what the patient needs, which is to have their back pain managed. So what you want to do to be able to change that is to say, well, let's actually pay the physicians for spending the time to evaluate the patient, explain to them what the alternatives are, and be able to develop a good treatment plan. So I'm going to suggest this for purposes of discussion tonight, that we'd basically double the amount that gets paid for the evaluations from $160 to $300. And I'm going to propose that we double the amount that gets paid to the physician for managing the patient's care when they don't get surgery. And if we did that, what we would end up doing is we'd be paying the physicians better, obviously. But if we can, in fact, result in a reduction in the number of surgeries by doing that, we would still be able to save money for the payer. And we could even say, let's pay the surgeons more. Let's pay the surgeons more for each individual surgery than they're getting paid today, because they're going to be doing fewer surgeries. And so from their perspective, in terms of income and managing practice expenses, they need to be able to recover that. So I'm going to suggest that we actually increase the amount that's paid for the surgeons. Now, if we did all of that, that would be a win for the physicians, being paid more both for the non-surgical management and for the surgery management. And if it would allow fewer surgeries to be done, you would actually have the payer spending less. And when my slides catch up, you will actually be able to see all of these numbers. But the internet seems to be slow right now. So the challenge that you face in all this is that it's pretty easy to make the physicians win under these kinds of approaches and to make the payer win. Where the difficulty comes up is the hospital, because that's where all the money is, and that's, if you're going to be able to save money in healthcare, that's where the savings has to come from. So the challenge is, can you do this in a way that enables the hospital to win? And obviously, if you work for a hospital, that's a pretty important thing. But even if you don't work for a hospital, you want to make sure that your hospital and your community can still be financially viable and continue to function successfully. So, what should matter to hospitals really is their margins, not their revenues. And the problem is the way we pay hospitals today is that the only way they can improve their margins is to be able to do more procedures. So, for example, hypothetically, if you had a 20% reduction in volume in a hospital, so you kept the chronic disease patients well and you had fewer readmissions and you did fewer unnecessary surgeries, the hospital's costs might only go down by 7%. If you assume that 2/3 of the hospital's costs across the board are fixed. So 20% reduction in volume, 7% reduction in cost, but the payers will happily pay 20% less if they have 20% fewer patients getting hospital care. And you don't exactly need an advanced degree in hospital finance to know what it means if you've got 20% less revenue but only 7% less cost. You are losing money. But what it also means is that if the payers were paying the right amount at the beginning for each patient admission, they probably weren't, but if they were, they are no longer paying the right amount, because the hospital has a lot of fixed costs that they have to maintain, the surgery suite and the ER, et cetera. And if they have fewer patients coming in, then they have fewer patients to spread those fixed costs across. So their cost of care per patient is going to go up. But the win-win opportunity is that if you could actually then pay the hospital the right amount, their costs are going to be lower. They're just not going to be 20% lower. You could end up with a win-win, because you could cover the hospital's costs without causing them negative margins and still save money for the payer. So let me show this concept in the numbers. And again, it'll take a few seconds for the slides to catch up here. But what I want to look at is my hospital was getting paid $22,000 for each of these inpatient admissions. What I want to know is, where is that money going? And I'm going to assume, in the case of back pain for back surgery, that about 1/3 of the hospital's costs are fixed. They're the cost of the surgery suite and equipment, et cetera. I'm going to assume that about, in my example, 59% of the costs are variable. That's the implant and the disposables and everything else associated with the surgery. And I'm going to assume that the hospital's getting a 5% margin on each of these procedures. So what happens if that's what the hospital's money is going to? What happens if they reduce the number of surgeries by 10%, from 200 to 180? Well, the hospital's fixed costs, that $1.58 million are fixed, and so the hospital still needs to get $1.58 million. The variable costs are variable. So if I'm doing 10% fewer procedures, then I have 10% less variable costs, and that's a pretty significant amount of money. That's $250,000 on the variable costs. And if the physicians are making more money, then we should probably pay the hospital some more, but what we pay them more on is their margin. So I'm going to increase their hospital margin, that's the $220,000, up to $231,000. Now, if I keep the fixed cost fixed and I reduce the variable cost and I increase the margin, what do I end up with? Well, what I end up with is actually a total of 6% less revenue than the hospital was getting before. But should the hospital care? If it's covering its fixed costs, if it's covering its variable costs, and it's getting a higher contribution margin on the procedures, then 6% less revenue is actually okay. Not 20%, not 10% less revenue with 10% fewer procedures, but 6% is something that they can manage. And if you add all that up, you actually end up with the payer spending 5% less than they were before. So you end up with a win-win-win because the physicians are making more money. The hospital is making more money where it counts, which is on its margin, and the payer is spending less money. So genuine win-win-win. Now, how do you actually implement this? Well, you don't really want to go and try to renegotiate all the individual fees. So I proposed different fees for the physicians, and this would actually end up being a higher payment to the hospital per patient, but that's going to not go very far with payers whenever you go and say, let's change all the individual fees, because the payer doesn't know whether you're actually going to reduce the number of procedures by 10%. So what you really want to do is you want to be able to say, let's look at these 300 patients who have back pain, and what are we spending on them today? We are spending $16,500 per patient on these patients today. And if we think that we can do that for 5% less, then give us the 5% less money for each of the patients. Give us about $16,000 per patient, and then let us figure out how to use that money to cover the hospital costs and cover the physician costs and figure out how the physician should be paid. So it doesn't get determined by an external payer what the physicians in the hospital get paid. The physicians in the hospital decide themselves how to allocate the money within that smaller budget, but a budget that the physicians in hospitals have determined that they can in fact live within because they've understood what the costs are, and they understood how many avoidable surgeries they are doing. Now, this model doesn't work terribly well under the shared savings model that payers are using. And because we're running kind of slow here tonight and I don't want to run out of time, I'm going to skip over the discussion about the shared savings. And you can look at that whenever you get the slides to look at after the webinar. But the problem with shared savings is that it creates an arbitrary number after the fact to give to the hospital and the physician to be able to get, and it may or may not cover the hospital's costs. What you really want is a system where you determine up front how much the hospital and the physicians need, and they get that money up front, and then let them have the flexibility to deal with that. Now, payers like shared savings for a simple reason. It's easy for them to implement. They don't have to change anything about the way doctors and hospitals are paid. They only make additional payments if you actually achieve savings. They decide how to determine whether savings are calculated. They make those payments well after the savings are achieved, so it's good for their cash flow. And then the very best part of all is under shared savings contracts, at the end, after a 3-year period, for example, in Medicare, all the savings goes back to them, and the doctors and the hospitals are left in the exact same fee-for-service system they started out in, but with less revenue. So the notion of condition-based payment, while it might sound a little scary, is actually a whole lot better because it puts the doctors and the hospitals in charge of their own destiny in terms of what they need to be able to manage care. Now, a lot of people are concerned about risk, and Again, I'm going to jump over some things here in the interest of time. And what the notion of risk is that what if it would turn out that the costs are actually higher than what the payment is that you're getting? Well, what you have to do is you have to say, well, what are the reasons why the costs might be higher than what I'm getting paid? And there's a lot of different reasons. It could be avoidable complications, failure to follow guidelines, overutilization of services. It could also be large random variation. New high-cost treatment comes along, you get an unusually costly patient, or you have higher severity patients. Which kind of costs are built in and which are not as important? Those top three that I listed there, avoidable complications and failure to follow guidelines and overutilization of services, are the things that physicians can control. And that's what's referred to as performance risk. The other thing, whether the patients are sicker or whether they have some unusual problem that couldn't have been predicted or some new treatment comes along that really requires that to be used, those are things that physicians can't control. And that's what's referred to as insurance risk. So what you want to do in a payment model is to say we want to protect the physicians and the hospitals from the insurance risk while having them take responsibility for the performance risk, which is the things that they can actually manage. And there's four basic techniques that you use in a payment model to be able to protect the physicians and hospitals against the insurance risk. And that's the notion of risk adjustment, outlier payments, or what's sometimes called stop loss, risk exclusions, and risk corridors. And I'm not going to take the time tonight to try to explain those, but those are important features that need to get built into a model to be able to ensure that the physicians are protected against this. And a lot of people think that somehow, this is a new thing for physicians to be having any kind of risk in the payment system. But the truth is physicians have risk today. They've always had risk. Their risk today is, are they going to get the right kind of payment from payers to be able to cover their costs? Are they going to get enough patients to be able to, and enough procedures to be able to generate revenues for their practices? So there's risks under the new payment models. They're just different risks than the risks that physicians have today. Physicians are used to the risks they have today. These are new kinds of risks, but they're also new kinds of opportunities that help them improve. And what's important to do is to think about what are the opportunities. And if you think about in physiatry, there's a lot of opportunities in the kinds of patients that physiatrists deal with. Patients who are injured, patients who have stroke, patients who have back pain. And those opportunities are things like using lower cost post-acute care, reducing readmissions, getting patients back to work faster, using effective alternatives to surgery. And any of these payment reforms need to start with what are those opportunities to improve care and reduce costs. But then there are barriers in the current payment system that you cannot easily change who can get what kind of post-acute care, and you don't get enough payment to be able to manage outpatient care for the patients, et cetera. So the idea of the accountable payment models that we've been talking about, condition-based payment and bundles and warranties, et cetera, is to let physicians and potentially let physiatrists be able to take advantage of those opportunities they have to be able to improve care and reduce costs by reducing the barriers that exist in the current payment system. And since we're running along there, I'm going to basically stop there. I was going to talk a little bit about how ACOs work. But I think that these concepts, while they are complicated, they are very important, because if we're really going to be able to control costs effectively in healthcare, do it in a way that doesn't harm patients, and most importantly, in some ways, enables physician practices and hospitals to remain financially viable. We've got to change the way we pay for care. And I often refer to this as a different triple aim. My triple aim is better care for patients, where physicians have the flexibility to design care that matches patient needs. Lower spending for payers, with, again, physicians deciding what's the right combination of services for patients without having to worry about what generates profits, and then having financially viable physician practices and hospitals that can continue to provide good quality care. So there's a lot of free materials on the website that you'll see whenever the slides catch up with that. And I will stop there and see if anybody has any questions about any of this. If you do have a question, just say, I have a question in the chat box, and let us know. I think we can open up the phone lines. Is that right? We can open up the phone lines for people?
Yes, the phone lines are open.
We can. So anybody has a question, just have a question in the chat box. And
It's on some rice recipe or something.
Carol, there is one question that was typed into the questions box. Can you see that?
Okay. You want me to type it, or do you want to type it?
Sure, you can say I'm an independent interventional physiatrist doing...
I'm not.
Well, whatever.
Okay,
So
go ahead.
rephrase it. So, how would an independent interventional physiatrist performing a lot of pain management procedures for primarily chronic pathologies that do not require surgery operate within this paradigm, period. My patients...
Oh, he said, I thought that was the question.
Okay, that works. And
Yeah, that's why. What do you want to add? What did you want to say?
my patients rarely require any hospitalization or surgery.
What else? Is that it?
And
Sorry.
I'm thinking, Bucky. That's fine.
okay, what I was going to say is I could actually hear you reading the question. You didn't need to type it, and I can't see it. So if you could just tell me what it is again, I'll be happy to answer it. Can you all hear me?
Yes.
Okay, so just read me the question again. Don't type it. Read it. Just tell me verbally what it said.
Can you hear me?
Yes, go ahead.
So I'm an independently practicing interventional physiatrist.
Yep.
I practice a lot of pain medicine procedures for primarily chronic pathologies that do not warrant surgery. How would I operate within this paradigm, since I'm not really part of a hospital system? I occasionally refer to them for additional consultation, but most of my patients I manage in-house with an in-office fluoroscopic or ultrasound procedure suite. So I could see a payer looking at what I do saying, well, how are we really saving costs on this doctor, because we're not saving any surgical costs?
Well, I gave the surgical cost example in case that's just one example. So the basic important principle here is, what do you think the opportunity is that you have for the patients that you manage to be able to do better for the patient in a way that would be lower cost? Now, it may be that, in fact, there isn't any way to do it at lower cost, but you could achieve a better outcome. So, for example, on a commercial side, if you could actually get that patient back to work faster, and have a better outcome in terms of their ability to work, to function, to whatever, that might be the value that you create. And what you want is to be able to have the flexibility to be able to put together a different package of services to be able to do that. Or if you're simply doing better than other modes that are being used for the patient, you would say, I should be rewarded for the fact that I get patients back to work faster. This is one of the things that you really can't do in Medicare, because I don't want to say Medicare doesn't care about how fast patients recover, but I mean it's not as important sort of in a quantitative, monetary way as it is to employers. Employers see a huge value if they can actually get people productive again, as opposed to simply are they saving money on healthcare. And again, I didn't have time tonight to go into all that, but depending on who the payer is, if on the commercial side, that may be the real value that you could potentially offer. If there are complications that you avoid, so back to the warranty model. So if you, if some other physician practice or other method of dealing with the patient's condition would end up down the road with them having complications or being admitted to the hospital or whatever it is, or getting some more expensive approach, then you could basically build that into your warranty, if you will, or have an outcome associated with it that says that we're going to be measured based on how effectively we can avoid those problems downstream. That's where it becomes complicated in terms of the data, because you would want to be able to know how often for your patients they end up having those kinds of problems, which maybe after they leave out of your care, but you would want to find a way of saying, I should get credit for the fact that I actually dealt with this problem more effectively than others would, and I want to be paid for that. Does that help?
Sure, that's been my argument all along. I've had one complication in 4 years, but I don't get paid more for it. I just get patients who like me.
Well, patients liking you is not a bad thing. What I didn't get time to go through tonight was the notion of, accountable care organizations are basically the idea we're going to be managing a patient population. And what hasn't been really dealt with is, so how do we actually change the way the patients are actually experiencing care inside that accountable care organization? What most ACOs are doing is they're spending a whole lot of money on information systems and hiring nurse care managers and stuff to work with patients, and they're not doing anything, in some cases not even talking to the docs, in the system. But that's who the patients experience. And one of the big concerns of ACOs is they want to be able to keep patients inside their system so that they can basically manage their costs better. Well, you keep patients inside your system by having them happy with the care that they're giving. So if you can, in fact, show that, for the set of patients that you deal with, that they get good quality care, good patient experience, and you're saving money where the opportunities are to save money, that makes you a valuable prospect for an ACO to have.
Sure. Thank you.
Yep. Other questions anybody has that I can answer?
Carol, this is Kavita. There is a question typed in that I'll read back to you. Can you hear me?
Yes, I can hear you.
Okay, great. How will the ACO model impact inpatient rehabilitation on units that are primarily volume-based and are currently paid under a prospective payment system?
Well, it depends on whether we have the current ACO system or what the ACO system should look like. The current ACO system is based totally on a continue to be paid. Everybody's paid exactly the way they are today. And then if you can save some money, you get some shared savings. But if you talk about if you talk about moving to a condition-based payment, which is sort of a global budget model, then you could say, all right, well, I actually in some cases may need more money for some patients than I'm getting in the prospective payment system, and I need less for other patients. So if I have the flexibility in the payment system to be able to deal with that, then I don't have to worry anymore about the fact that I am dealing with one fewer patient than I'm getting paid for, or spending more time on a patient than I'm getting paid for. I have the flexibility to be able to deal with that because I'm getting an overall budget. And that's what, for example, Massachusetts Blue Cross Blue Shield is doing in Massachusetts, is giving a group of providers, and they're even doing this with small groups of primary care physicians, saying here's an overall budget for managing the care of patients. and you have the flexibility to figure out how you want to change within that, because that's your budget. If you spend less than that, then you will be able to get that back. So it enables a lot of flexibility to be able to redesign care. And one of the important things about the Massachusetts Blue Cross Blue Shield system is that it's a 5-year contract. So you actually, and this is one of the problems with a lot of these other deals, is that it takes time to be able to redesign care. And you want to be able to reap the benefits of that, have enough time to put it in place, and to be able to reap the benefits of it. And one of the problems in the current Medicare Shared Savings Program is that it's only a 3-year contract, and then all the savings goes back. So it really causes a lot of, I guess I would call it, and that's what I would call the risk of the system, is the fear that by the time I get a significant change in care in place, I will have lost a bunch of money and I will not be able to really recoup it under the payment system. So what's critical is not just being a quote-unquote ACO, but what is the payment model for the ACO? And that's one of the things that I and others have been trying to work on, is to get a better payment system for the ACOs so that they can actually deal with things like that. Any other questions that I could answer?
There's one more here. How does medical malpractice factor into all of this?
Well, I think the concern that exists today is, on a lot of patients' part, is that they are injured and there is basically no way for them to be able to get recompense without having to sue. And if you think about this model, the notion of the warranty, you could say that we could even build into our system a warranty, and that if there's an injury, we will compensate you for it. And I think that that's one of the reasons, that's one of the fundamental problems that exist in malpractice today, is that people, now obviously there's attorneys that want to generate, big fees, but I think a lot of patients feel like as if basically the current system basically charges more when there's a problem and doesn't do anything to try to deal with a problem. So the warranty turns that all around. It's a very different kind of approach that healthcare providers would be offering to patients, is to say we're taking accountability for our outcomes. We will correct them if we have a problem, if we can. We will not get paid more for dealing with them. But we want you to pay us more to be able to deliver the good quality care that you need. So it would hopefully, the better payment would reduce the likelihood of errors, and also create a better sense that that's being dealt with. And so I think then if you could add, it would make it a whole lot easier to get some of the other kind of malpractice reforms that are necessary in place, like limits on damages and not pursuing frivolous suits, if in fact the healthcare system was taking a proactive step to say, here's what we're doing to try to both improve care and take accountability for outcomes.
Harold, we have one more question I think we can close with.
Okay.
In the bundled payment win-win-win scenario, the system provides bundled care for 1% less and shifts funds within the system. If that model of care is successful, what is to prevent the payer, insurance companies, employers, government, from cutting the payment rates in future years? Payers can decrease payments, forcing the system to find another 1% cost reduction to continue the win-win-win.
Sure, and there's no reason why they can't do that today, too. The problem is today they will cut individual fees, and you don't have any flexibility at all to be able to redesign care with that. Now, the reason why, now, you can never protect yourself against what I would call an unscrupulous payer who simply wants to demand lower payments regardless, and if they're big enough to put that in place. But why are people cutting fees today? Well, because they need to save money, and we're not giving them a better alternative. So if the providers would actually go to the payers, and what I would suggest is that it's not health plans they should be talking to, it's the private employers who are actually the ones that are paying for care, and say, we are actually giving you care, good quality care, at the lowest cost that we can, then you're actually reducing the likelihood that somebody is going to simply cut your fees because they want to, because you actually can make a case that you're delivering care effectively. And you also have the ability to continue to find ways to be able to redesign care without being limited by the current payment system. So there's no greater ability on the part of a payer to cut payments under this system than there is under the current system. They can cut payments, completely. And what this approach provides is a greater ability to rearrange the care within the payment structure than exists today. Because if they cut you for one particular procedure, you don't have the flexibility to do something else and be able to get paid more for that. So with that, I thank you all for your attention. I'd be happy to answer any questions by email if you have them. And as mentioned at the beginning, we'll make the slides available to you electronically, so you'll have a chance to be able to hopefully see the numbers in a little less jerky fashion than they appeared on the screen tonight. But thank you all for your time.
Great. Thank you all, and thank you, Harold.
You're most welcome. Thanks all for your time.